According to body mass index, the cutoff for obesity is A. 25 kg per meter squared, B. 30 kg per meter squared, C. 35 kg per meter squared, D. 40 kg per meter squared. Correct answer B. 30 kg per meter squared. The International Classification of Adult Underweight, Overweight and Obesity according to BMI is as follows. Underweight less than 18.5. Normal range 18.5 to 24.99. Overweight more than or equal to 25. Pre-obese 25 to 29.99. Obese more than or equal to 30. Obese class 1 30 to 34.99. Obese class 2 35 to 39.99. Obese class 3 more than or equal to 40. All of the following are seen in hyperkalemia except A. PR interval prolongation, B. Tall tended T waves, C. Diminished P wave amplitude, D. Narrow QRS complex. Correct answer D. Narrow QRS complex. QRS widening is a feature of severe hyperkalemia in such a way that QRS complex merges with the T wave to produce the sine wave pattern. Diminished P wave amplitude and atrial paralysis in hyperkalemia leads to sinoventricular conduction. It is mentioned that sinoventricular conduction can be differentiated from junctional and ventricular rhythms by the presence of respiratory variation in cycle length, sinus arrhythmia, which will not be seen in the latter two conditions. Which of the following is not true about abciximab? A. Glycoprotein 2B3A blocker, B. Orally active, C. Monoclonal, D. Was used as an adjunct in PCI. Correct answer B. Orally active. Abciximab is an intravenous glycoprotein 2B3A blocker which is a monoclonal antibody useful as an adjunct in percutaneous coronary intervention when there is a thrombus load in the coronary artery. Glycoprotein 2B3A receptor is the final common pathway for platelet. Gross enlargement of cardiac shadow on chest X-ray is unlikely in A. Tetralogy of Fallot, B. Pericardial effusion, C. Multivalvular heart disease, D. Epstein's anomaly of tricuspid valve. Correct answer A. Tetralogy of Fallot. Gross enlargement of the cardiac celote is unlikely in tetralogy of Fallot as there is no dilatation of cardiac chambers in this condition, though the right ventricle is hypertrophied. In pericardial effusion and posterior mediastinal tumor, though the cardiac size itself is not enlarged, the shadow on chest X-ray can be large, mimicking cardiomegaly. In Epstein's anomaly of tricuspid valve, a large right atrium along with atrialized portion of the right ventricle produces the enlargement in cardiac celote. Coarctation of aorta is associated with all except A. Endocardial fibroelastosis, B. Mycotic aneurysm, C. Aortic dissection, D. Bicuspid aortic valve. Correct answer B. Mycotic aneurysm. Mycotic aneurysm is seen in infective endocarditis. All other conditions have been reported in association with coarctation of aorta. Berry aneurysms can occur in about a tenth of patients with coarctation of aorta. High right ventricular pressure is found in A. Epstein's anomaly of the tricuspid valve, B. Isolated right ventricular endomyocardial fibrosis, C. Pulmonary atresia with intact interventricular septum, D. Wool's anomaly. Correct answer C. Pulmonary atresia with intact interventricular septum. Wool's anomaly is otherwise known as parchment right ventricle. Natural prothrombotic is A. Thrombospondin, B. Thrombomodulin, C. Plasminogen activator inhibitor, D. Protein C. Correct answer C. Plasminogen activator inhibitor. Thrombospondins are proteins with anti-angiogenic properties. Thrombomodulin is a cofactor in the thrombin-induced activation of protein C, which is a natural anticoagulant. Pulsus paradoxus may be seen in all except A. Obesity, B. Pregnancy, C. Aortic regurgitation, D. Cardiac tamponade. Correct answer C. Aortic regurgitation. Pulsus paradoxus is an important finding in cardiac tamponade. It can also occur in chronic obstructive pulmonary disease. It is rare in constrictive pericarditis. It may also be observed rarely in pulmonary embolism, marked obesity, pregnancy, and partial obstruction of the superior vena cava. On the other hand, in those with aortic regurgitation and atrial septal defect, pulsus paradoxus may not occur even if there is associated cardiac tamponade. Reverse pulsus paradoxus or inspiratory rise of arterial pressure may be noted in hypertrophic cardiomyopathy, intermittent positive pressure ventilation, and isorhythmic AV dissociation. Central cyanosis can be manifested in all except A. Reduced hemoglobin more than 5 gram percent, B. Sulfhemoglobin more than 0.5 gram percent, C. Reduced hemoglobin 2 gram percent, D. Oxygen saturation below 85%. Correct answer C. Reduced hemoglobin 2 gram percent. In general, cyanosis becomes apparent when the deoxyhemoglobin content in capillary blood becomes 4 to 6 gram percent. Cyanosis is detectable with methemoglobin levels 1.5% and sulfhemoglobin levels of 0.5 gram percent. ECG lead 2 has A. Positive pole at left leg and negative pole at right arm, B. Positive pole at right leg and negative pole at left arm, C. Positive pole at left arm and negative pole at right arm, D. Negative pole at right leg and positive pole at left arm. Correct answer A. Positive pole at left leg and negative pole at right arm. Right leg electrode is a ground electrode and does not come in the configuration of any of the ECG leads. It is usually colored black to indicate this. Option C is the configuration of lead 1. Lead 3 has negative pole on left arm and positive pole on left leg. Wilson's central terminal is found by A. Placing an electrode exactly at the center of manubrium sternum, B. Connecting right arm, left arm and left leg electrodes together through a 500 ohms resistor, C. Connecting left arm, left leg and right leg electrodes together through a 1000 ohms resistor, D. Placing an electrode at the location of the apex beat. Correct answer B. Connecting right arm, left arm and left leg electrodes through a 5000 ohms resistor. Wilson's central terminal serves as the negative pole for all chest leads V1 to V6. It is considered as a theoretical zero reference potential. Most commonly monitored ECG lead in cardiac monitors: A. Lead 1, B. Lead 2, C. Lead 3, D. Lead V4. Correct answer B. Lead 2. Lead 2 is used for continuous monitoring because it gives a good P wave and a reasonable QRS complex for fair delineation of rhythm abnormalities. If ST segment monitoring in acute coronary syndrome is the aim of monitoring, V5 may be a better lead as ST shifts are often well seen in chest leads. In inferior leads, the amplitude of ST shifts are generally lower. It is always a good practice to look at the baseline ECG to choose which lead to monitor in each person. If lead 2 is almost equiphasic in the given person, monitoring lead 2 may give a lot of false asystole alarms and cause alarm fatigue for the staff so that they may not attend a true alarm later. Einthoven's law or Einthoven's equation for ECG leads is regarding potentials in standard ECG limb leads 1, 2 and 3 and can be stated as A. 1 plus 2 is equal to 3, B. 1 plus 3 is equal to 2, C. 3 minus 1 is equal to 2, D. 2 minus 1 is equal to 3. Correct answer B. 1 plus 3 is equal to 2. This means that the orientation of standard limb leads is in such a way that the sum of potentials of lead 1 and 3 equals that in lead 2. Einthoven's triangle is formed by these leads as sides and theoretically has the heart at its electrical center, though it may seem too much of a simplification if you go into exact principles of physics. Standard recording speed of an electrocardiographic paper is A. 10 mm per second, B. 25 mm per second, C. 50 mm per second, D. 100 mm per second. Correct answer B. 25 mm per second. With standard recording speed, 1 mm on the horizontal axis of the ECG graph will represent 40 milliseconds. Standardization for recording voltage is 10 mm to 1 millivolt. Hence, 1 mm on the vertical axis of the ECG graph will represent 0.1 millivolt or 100 microvolts. In fast rhythms, sometimes we may resort to higher speeds like 50 millimeters per second. It may be noted that intracardiac electrograms during electrophysiology study is much higher at 100 to 200 millimeters per second. It is essential to recognize subtle differences in the intracardiac activation patterns to decipher the origin and mechanism of heart rhythm disorders. The effect of angiotensin II on erythropoietin production is A. Increase, B. Decrease, C. No effect, D. Bimodal. Correct answer A. Increase. This is due to decreased renal blood flow. Inhibition of the renin-angiotensin system with ACE inhibitors or ARBs can decrease erythropoietin secretion and cause anemia. Normal clinic blood pressure with elevated ambulatory BP is called A. White coat hypertension, B. Masked hypertension, C. Resistant hypertension, D. Postural hypertension. Correct answer B. Masked hypertension. The reverse is seen in white coat hypertension. Masked hypertension can be suspected with higher values being recorded from home measurements. Masked hypertension has an adverse cardiovascular impact. Non-dippers are those persons whose blood pressure at night does not dip -% below daytime blood pressure. A. 10%, B. 15%, C. 20%, D. 25%. Correct answer A. 10%. Non-dippers have a higher risk of stroke. The diurnal variation in blood pressure is recorded by ambulatory BP monitoring. True about tolvaptan. A. ADH antagonist. B. Rifampicin can decrease its efficacy. C. Cyclosporin can increase its effect. D. All of the above. Correct answer D. All of the above. Effects of rifampicin and cyclosporin are because of the influence on tolvaptan metabolism by the CYP3A pathway. Antidiuretic hormone is an A. octapeptide, B. decapeptide, C. pentapeptide, D. None of the above. Correct answer A. octapeptide. The central effects of ADH are mediated by V1A and B receptors and the peripheral effects by V2. Which of the following is not a major manifestation of rheumatic fever? A. Carditis, B. Chorea, C. Polyarthritis, D. Prolonged PR interval. Correct answer D. Prolonged PR interval. Prolonged PR interval is not considered to be an evidence of carditis and hence not a major manifestation. Which of the following are more common in females than in males? A. Primary pulmonary hypertension, B. Patent ductus arteriosus, C. Secondum atrial septal defect, D. All of the above. Correct answer D. All of the above. 65 to 75% secondum ASTs occur in females, while the gender distribution is equal for sinus venosus and ostium primum ASTs. Primary pulmonary hypertension is twice as common in females than males. Patent ductus arteriosus is twice as common in girls than boys. Drug which can shorten QT interval in LQT3. A. Amiodarone, B. Quinidine, C. Procainamide, D. Mexiletine. Correct answer D. Mexiletine. In LQT3, there is excessive inward sodium current which is blocked by mexiletine, but this effect may not be seen in all cases of LQT3. Most common cause of death in older women. A. Uterine malignancy, B. Carcinoma breast, C. Cardiovascular disease, D. None of the above. Correct answer C. Cardiovascular disease. T-wave inversion in anterior chest leads in young females is most likely due to A. Acute myocardial infarction, B. Acute pulmonary embolism, C. Persistence of juvenile pattern, D. None of the above. Correct answer C. Persistence of juvenile pattern. Juvenile pattern is the inversion of T waves in anterior chest leads seen in children and can persist in young adulthood in females. It becomes normalized earlier in males. Which of the following are risk factors for sudden cardiac death in hypertrophic cardiomyopathy? A. Family history of one or more HCM related sudden cardiac deaths. B. Massive left ventricular hypertrophy, thickness of 30 millimeters or more. C. One or more episodes of recent syncope. D. All of the above. Correct answer D. All of the above. In addition, non-sustained ventricular tachycardia noted on several occasions and hypotensive or attenuated blood pressure response during exercise are also thought to be important risk factors. It is needless to say that a previous episode of resuscitated ventricular fibrillation or sustained ventricular tachycardia is the strongest risk factor for a recurrent episode. Other potential factors are scars of alcohol septal ablation, apical aneurysm, end-stage disease, and delayed myocardial contrast enhancement seen on cardiac magnetic resonance imaging. Recommended INR value for mechanical prosthesis at mitral position: A 1 to 2, B 1.5 to 2.5, C 2 to 3, D 2.5 to 3.5. Correct answer D 2.5 to 3.5. Mechanical prosthesis at mitral position has higher chance of thrombosis than one at aortic position due to the lower pressure gradient across it. Hence, the recommended value of INR for a mitral prosthesis is 2.5 to 3.5, while it is only 2 to 3 for an aortic prosthesis. Low-dose aspirin is also often added along with warfarin in case of metallic mitral prosthesis to reduce the chance of thromboembolic complications. IVC plethora is seen in all of the following except A. Acute left ventricular failure, B. Chronic right heart failure, C. Cardiac tamponade, D. Constrictive pericarditis. Correct answer A. Acute left ventricular failure. Plethora of inferior vena cava is lack of the normal inspiratory collapse of the IVC on echocardiography. Normally, the IVC diameter decreases about 50% during inspiration. Prosthetic valve thrombosis is most likely at A. Aortic position, B. Mitral position, C. Tricuspid position, D. Pulmonary position. Correct answer C. Tricuspid position. Prosthetic valve thrombosis is most likely to occur at tricuspid position because the pressure gradient across that valve is the least. But mechanical prosthetic valves are seldom used in tricuspid position, where bioprosthesis is preferred because of lower thrombogenicity and lesser degeneration at this position. Being much more in use, among cases of prosthetic valve thrombosis, most cases will be of mitral prosthetic valve thrombosis, where the pressure gradient is less than across one at aortic position. Which of the following is not a feature of left atrial overload on the ECG? A. Wide notched P waves in lead 2, B. Prominent negative component of P wave in V1, C. Tall peak P waves in V1, D. Area of negative component of P wave in V1 of more than 1 Ashman unit. Correct answer C. Tall peak P waves in V1. Tall initial component of P wave in V1 would indicate right atrial enlargement. Uni-component peak P waves in V1 could also be due to an abnormal atrial rhythm. Ashman unit is the area corresponding to 1 small square or 1 square millimeter in a standard ECG taken with a paper speed of 25 millimeters per second and standardization of 1 centimeter to a millivolt. It will be expressed as 0.004 millivolt second. P tricuspidale is A. Tall P waves in V1, B. Tall P waves in lead 2 with initial peak taller than second peak, C. Tall P waves in lead 2 with second peak taller than first peak, D. Tall P waves in lead 2. Correct answer B. Tall P waves in lead 2 with initial peak taller than second peak. The original description of P tricuspidale was by Zuckerman in 1952. The pattern is a mirror image of P mitral in which the second peak is taller. P tricuspidale was noted by Gamboa and associates in 81% of their 37 patients with tricuspid atresia, while it was seen in only 2 of their 20 patients with pulmonary atresia. False statement regarding A and V waves in atrial pressure tracing. A. Right atrial A wave is taller than V wave. B. Left atrial V wave is taller than A wave. C. In atrial septal defect, A and V waves are equal. D. None of the above. Correct answer D. None of the above. Normally, A wave is taller in the right atrium and V wave is taller in the left atrium. In atrial septal defect, A and V waves are equal due to equalization of atrial pressures by the large unrestricted communication. Osler's sign is seen with A. White coat hypertension, B. Postural hypotension, C. Pseudohypertension, D. Postural orthostatic tachycardia. Correct answer C. Pseudohypertension. Osler's sign is the palpability of the radial artery after occluding the brachial artery by compression. This indicates a thickened arterial wall and can cause falsely high blood pressure to be recorded by a sphygmomanometer due to poor compressibility of the arteries with the cuff. Another method is using 3 fingers applied over the radial artery trisection, with proximal and distal fingers giving compression to obliterate the flow from either side and middle finger palpating the vessel. NYHA class 2 corresponds to the following level of Goldman specific activity scale: A less than 2 meds, B 5 to 7 meds, C more than 7 meds, D 2 to 5 meds. Correct answer B 5 to 7 meds. Goldman specific activity scale corresponds to NYHA class approximately in the following steps: NYHA class 1 more than 7 meds, NYHA class 2 5 to 7 meds, NYHA class 3 2 to 5 meds, NYHA class 4 less than 2 meds. 1 med is the metabolic equivalent corresponding to the basal metabolic oxygen consumption, 3.5 ml oxygen per kilogram per minute in a resting state. It will also correspond to 1 kilocalorie per kg per minute of energy utilization. 1 met can also be taken as 58.2 watts per square meter of body surface area. Sleeping has a met value of 0.9, while running at 22.5 km per hour would correspond to a met value of 23. Phase 4 of Korokov sounds are taken into consideration while recording blood pressure in all of the following conditions except A. Chronic severe aortic regurgitation, B. Secondary hypertension, C. Children, D. Pregnancy. Correct answer B. Secondary hypertension. Korokov sounds may be heard even up to 0 mm of mercury in some of these conditions. Intrinsic heart rate is A. Normal heart rate, B. Heart rate after total sympathetic blockade, C. Heart rate after total sympathetic and parasympathetic blockade, D. Heart rate after total parasympathetic blockade. Correct answer C. Heart rate after total sympathetic and parasympathetic blockade. Intrinsic heart rate is measured after total autonomic blockade with a combination of propranolol and atropine. It indicates the basic rhythmicity of the sinoatrial node without any autonomic influence. It is calculated by the formula IHR is equal to 117.2 minus 0.53 into H beats per minute. Familial myxoma is part of A. Holt-Oram syndrome, B. Eisenmenger complex, C. Down syndrome, D. Carney complex. Correct answer D. Carney complex. Carney complex constitutes about 10% of cardiac myxomas and is an autosomal dominant disorder. Myxomas may occur at multiple sites and recur even after complete surgical removal. Lentiginosis, hyperpigmentation, and endocrine dysfunction may be associated. Difference in X-ray chest findings between mitral restenosis after closed mitral valvotomy versus restenosis after balloon mitral valvotomy. A. Absence of features of pulmonary arterial hypertension. B. Absence of features of pulmonary venous hypertension. C. Absence of a prominent left atrial appendage shadow. D. Absence of double atrial contour of left atrial enlargement. Correct answer C. Absence of a prominent left atrial appendage shadow. Left atrial appendage is amputated during closed mitral valvotomy as it is an important site for thrombus formation. Hence, prominence of left atrial appendage shadow is unlikely in mitral restenosis after closed mitral valvotomy. Anisosphygmia may be seen in all of the following except A. Supravalvular aortic stenosis, B. Aortic dissection, C. Takayasu-arteritis, D. Aortic regurgitation. Correct answer D. Aortic regurgitation. Anisosphygmia or difference in the pulse volume or systolic pressure between two sides can occur in aortic dissection, Takayasu-arteritis and supravalvular aortic stenosis. In supravalvular aortic stenosis, it is due to the direction of the jet to the right side into the brachiocephalic artery, Coanda effect. The gene which is affected in Anderson syndrome LQT7 is A. KCNH2, B. SCN5A, C. KCNQ1, D. KCNJ2. Correct answer D. KCNJ2. In Anderson syndrome, KCNJ2, which codes for IK1 potassium channel KAR 2.1, is affected by a loss of function mutation. This results in a reduced outward potassium current. Anderson syndrome is characterized by long QT, periodic paralysis, and facial dysmorphic features. One of the characteristic arrhythmias in Anderson syndrome is bidirectional ventricular tachycardia. Commonest cause of syncope in the absence of structural heart disease: A. Ventricular tachycardia, B. Supraventricular tachycardia, C. Vasovagal syncope, D. None of the above. Correct answer C. Vasovagal syncope. Syncope is an important cause for visits to the emergency room, contributing to about 3% of emergency room admissions and 1 to 6% hospital admissions. Head-up tilt test is an important test for vasovagal syncope. Matrix metalloproteinase 3 is A. Interstitial collagenase, B. Gelatinase, C. Stromalysin, D. None of the above. Correct answer C. Stromalysin. Interstitial collagenase is MMP1 and gelatinase is MMP2. Matrix metalloproteinase 3 and other metalloproteinases are found in the shoulder region of vulnerable plaques and are important in the process of plaque rupture. Vulnerable plaques have a lipid-rich core and a thin fibrous cap, and they are prone for rupture. Rupture of a vulnerable plaque in the coronary artery causes local thrombus formation, leading to acute coronary syndrome and myocardial infarction. Which of the following is not a feature of vulnerable plaque? A. Thick fibrous cap, B. Large lipid-rich necrotic core, C. Increased plaque inflammation, D. Positive vascular remodeling. Correct answer A. Thick fibrous cap. Vulnerable plaque has a thin fibrous cap which is prone for rupture and consequent thrombus formation, leading to vessel occlusion. Survival in out-of-hospital cardiac arrest up to hospital discharge: A. 8%, B. 18%, C. 24%, D. 32%. Correct answer A. 8%. Out-of-hospital cardiac arrest has a very poor survival rate. Rates as low as 2% has been reported from Asia, while the rates from North America and Europe are higher. It can increase if bystander initiates CPR. Aspirin resistance is more likely to occur in diabetics due to A. Increased protein glycation due to hyperglycemia, B. Decrease in aspirin-mediated protein acetylation, C. Reduced sensitivity of platelets to aspirin, D. All of the above. Correct answer D. All of the above. These mechanisms act sequentially and contribute to relatively higher chance of aspirin resistance in diabetics. Mechanism of antiplatelet action of aspirin is by irreversible inhibition of COX-1 enzyme, thereby blocking the synthesis of thromboxane E2, a vasoconstrictor that promotes platelet aggregation. Clopidogrel is a P2Y12 receptor antagonist, B. GP2B3A inhibitor, C. Vitamin K antagonist, D. None of the above. Correct answer A. P2Y12 receptor antagonist. Clopidogrel, ticlopidin and prasugrel are P2Y12 receptor antagonists. GP2B3A inhibitors include apixaban, eptifibatide and tirofiban. Warfarin is a vitamin K antagonist. Best graft for coronary artery bypass grafting is A. Reversed saphenous vein, B. Left radial artery, C. Left internal mammary artery, D. None of the above. Correct answer C. Left internal mammary artery. Left internal mammary artery is the best available vessel for CABG. It has good long-term patency rate and provides a pulsatile flow. Saphenous vein grafts are prone for degeneration and thrombosis. Left radial artery being a free graft, unlike the in situ Lima graft, is inferior to Lima graft but probably superior to RSVG. Antiplatelet agent with reversible action. A. Prasugrel, B. Clopidogrel, C. Ticlopidin, D. Ticagrelor. Correct answer D. Ticagrelor. While prasugrel, clopidogrel and ticlopidin are thienopyridines, ticagrelor is a nucleoside analog with overall similarity to adenosine. As the action is reversible, it acts faster and shorter than clopidogrel. Hence, it has to be taken twice daily, while clopidogrel needs to be taken only once daily. But the reversible nature helps when the drug has to be withdrawn prior to surgery. Coronary artery disease is dash more common in diabetics than general population. A. 2 to 4 times, B. 5 to 8 times, C. 10 to 15 times, D. None of the above. Correct answer A. 2 to 4 times. Coronary artery disease occurs 2 to 3 decades earlier in diabetics than non-diabetics. Some even consider diabetes mellitus as a coronary artery disease equivalent. Mitral annulus is A. Circular, B. Elliptical, C. Saddle-shaped, D. None of the above. Correct answer C. Saddle-shaped. Mitral annulus is not a planar structure and has three-dimensional saddle shape. The shape of mitral annulus can change with annular dilatation as occurs in left ventricular volume overload. Barlow's disease is A. Bicuspid aortic valve, B. Mitral valve prolapse, C. Coarctation of aorta, D. None of the above. Correct answer B. Mitral valve prolapse. Barlow's disease is due to an excess myxomatous tissue in the mitral leaflets with accumulation of mucopolysaccharides. The mitral leaflets are bulky and redundant, prolapsing into the left atrium during systole. Mitral valve prolapse causes varying degrees of mitral regurgitation and is associated with a non-ejection mid-systolic click. Incidence of rheumatic fever is A. Declining worldwide, B. Increasing worldwide, C. Remaining unchanged, D. None of the above. Correct answer A. Declining worldwide. The incidence of rheumatic fever is declining worldwide, more so in developed countries. The reasons suggested are improvement in socio-economic conditions, better public health care, frequent use of antibiotics, and possibly a decrease in the virulence of streptococcal strains. The incidence ranges from 5.7 cases per thousand in worst affected regions to 0.3 cases per thousand in least affected regions. Pulmonary artery systolic pressure in mild mitral stenosis is A. Less than 30 millimeters of mercury, B. 30 to 50 millimeters of mercury, C. More than 50 millimeters of mercury, D. None of the above. Correct answer A. Less than 30 millimeters of mercury. Grading of severity of mitral stenosis from pulmonary artery systolic pressure can be as follows, though the actual grading is based on mitral valve area. Mild, less than 30 millimeters of mercury. Moderate, 30 to 50 millimeters of mercury. Severe, more than 50 millimeters of mercury. Mean gradient across the mitral valve in severe mitral stenosis. A. More than 10 millimeters of mercury, B. Less than 5 millimeters of mercury, C. Between 5 millimeters of mercury and 10 millimeters of mercury, D. None of the above. Correct answer A. More than 10 millimeters of mercury. Mitral stenosis can be graded according to mean transmitral pressure gradient as follows. Mild less than 5 millimeters of mercury, moderate 5 to 10 millimeters of mercury, severe more than 10 millimeters of mercury. Transmitral pressure gradient can be measured non-invasively by Doppler echocardiography. Invasive measurement is by cardiac catheterization. A modified Rankine score of 2 corresponds to A. No significant disability, B. Slight disability, C. Moderate disability, D. None of the above. Correct answer B. Slight disability. Modified Rankine score has been used to score the disability after cardiopulmonary resuscitation regarding the neurological outcome. It was originally proposed for the outcome of stroke management. 0 score corresponds to no symptoms, while score of 6 corresponds to death or no possibility of return of spontaneous circulation. Score 5 is a bedridden, incontinent person who needs constant nursing care. Beta adrenoceptor desensitization is mediated by A. G protein coupled receptor kinase, B. Cyclic AMP, C. Alpha adrenoceptor, D. None of the above. Correct answer A. G protein coupled receptor kinase. G protein coupled receptor kinase activation is prompted by catecholamines. GRK in turn induces phosphorylation of beta adrenoceptors, leading to beta arrestin binding and G protein uncoupling, shutting off beta adrenergic signaling. This regulation system is called beta adrenoceptor desensitization and accounts for downregulation of beta receptors with prolonged catecholinergic stimuli as well as pharmacologically administered beta stimulants. Lorcaserin is an A. Antihypertensive drug, B. Antidiabetic drug, C. Anti-obesity drug, D. None of the above. Correct answer C. Anti-obesity drug. Lorcaserin is indicated in those with body mass index more than 30 kg per meter squared or in those with 27 kg per meter squared and one additional risk factor like hypertension, type 2 diabetes mellitus or dyslipidemia. Which of the following is contraindicated in heart failure? A. Digoxin, B. ACE inhibitor, C. Beta blocker, D. None of the above. Correct answer D. None of the above. Although beta blockers will not be given in acute decompensated heart failure, chronic use of beta blockers in stable heart failure has been shown to increase survival. Other drugs useful in heart failure are angiotensin receptor neprilysin inhibitor ARNI, diuretics, and mineralocorticoid receptor antagonists. Patients with NYHA class 2 to 3 heart failure are more likely to die of A. Sudden cardiac death, B. Progressive pump failure, C. Non-cardiac causes, D. None of the above. Correct answer A. Sudden cardiac death. Patients with mild to moderate heart failure are more likely to die of ventricular arrhythmias rather than pump failure, while those in NYHA class 4 are more likely to die of progressive pump failure. But the mortality rate will be higher in NYHA class 4 rather than in class 2 to 3, and arrhythmic deaths do occur in class 4 heart failure as well.